Could you just give our listeners a brief background on who you are and what your position is?
Yes, I'm Janet Shapiro. I'm the director of the Medical Intensive Care Unit at Mount Sinai Morningside in New York City. And, I am the interim division chief for the Division of Pulmonary Critical Care and Sleep Medicine here at Mount Sinai Morningside. I direct the Medical Intensive Care Unit, but we work very closely with the other critical care units, especially the cardiac care unit. And during COVID, actually all of the critical care units were taking care of COVID patients, and that included the cardiac unit and the cardiothoracic surgery unit as well.
All right, thank you for that. And now just diving into our discussion then, before we talk about the recent article that you authored in JAMA Cardiology, from your perspective, can you take me through what the COVID-19 pandemic has been like as someone who directs an ICU? And if you could you take me through sort of the stages? I know early on, New York was among the hardest hit spots, but then I know sort of the restrictions that put in place allowed you guys to recover better than some places have. What's it been like throughout sort of the ebbs and flows of this pandemic for you?
Right. So starting in March, we started to see patients with COVID, and we really hit a peak in terms of COVID admissions and COVID patients in the intensive care units at the beginning of April. Our hospital became, filled with patients with COVID, just like other hospitals in New York City. So there were hundreds of patients with COVID in the hospital. And among critically ill patients, many of the patients were coming in with severe critical illness, mainly respiratory failure. And so we actually increased our intensive care unit beds by double. So in the different critical care units, such as the surgical units, the cardiac units, now all of those units were filled with patients with COVID, and the physicians, whether they be surgeons or cardiologists or critical care medicine physicians like myself, we were all managing patients with severe COVID illness, most of whom were requiring mechanical ventilation. So this lasted for several months, and I think that there were a lot of interventions put in place in New York City, to limit the spread of COVID, the masking, the social distancing, closing of restaurants and other places where people can gather, and so that there's really been a decrease. And right now, and for the past few weeks, there have been very few COVID patients in our hospital and in many of the hospitals in New York City. So it's quite a change from having so many patients who were so critically ill to now having very few patients who are critically ill. There are some patients who were critically ill, requiring mechanical ventilation, that have required a long term of mechanical ventilation, past the point of having infectious COVID, but just the result of COVID, in their lungs and organs.
It's really unfortunate to hear. I hadn't heard of any patients like that. And now, just lastly, before we dive into the article that you authored, I like to ask physicians, because it's different for people depending on where they practice and what specialty they're in. What was your attitude early on about the possibility of contracting COVID-19 from your occupation? Were you almost certain that you were going to get it? Did you think that there was a chance that you could avoid getting this disease throughout the entire pandemic? What was it like for you going to work thinking about this?
Yeah, that's a great question, because I think that was on the mind of everyone. I think that at the beginning, we had never seen anything like this. And really, I think that very quickly we all appreciated how severe this illness was, that it affected people of all ages, with all underlying diseases or no underlying diseases, and that it caused, unexpectedly so much more organ failures than just like influenza that affect the lungs. I mean, this disease affected all the organs, including the heart. And so, I think that there became a good amount of concern about getting COVID. I think that we were prepared in terms of PPE, our own personal protective equipment, and we never ran short of PPE. I think that we used it wisely. We limited exposure, and I think that that was a very big thing as well. And I know that other hospitals did this. Was that the physicians who had to go in to see the patients went in to see the patients. Other clinicians who did not need to go into to the rooms, or if the patient was in the intensive care unit, other clinicians did not need to go into the rooms. So there was I think often it was the attending physician, the nurses, the respiratory therapists, but also the personnel who cleaned the rooms. These were the people who had to be had to go into the rooms, but we really limited exposure for other people. And one thing that was an innovation that we did here, and I think that they did elsewhere, was to move some of the equipment that is generally in the room to outside the room, just with longer connections, so that changes can be made without the nurse always having to go back into the room, or the respiratory therapist always having to go back into the room. So I do think that there was concern. I think that, all hospitals had staff who were infected, and staff had to go home. There were staff who contracted COVID and had serious COVID, and there was loss of life in a lot of the institutions among staff who work there. So absolutely, it was a big concern. But I really felt that I really admired the courage of a lot of the staff who went into, obviously put on their PPE, but went into the rooms to take care of patients. The anesthesiologists who went in to put patients on ventilators, the nurses, the physicians, the respiratory therapists, the people, as I say, the people who, had to clean the rooms. I mean, everybody, I felt like was prepared, but went in to do it. The radiology technicians who went in to take the x-rays, the technologists who did ultrasounds and echocardiograms. I mean, I really commend everybody who did that.
All right, thank you for that. And yeah, it's definitely a situation that a lot of people, I think, had to be a bit mentally prepared for the possibility of it.
Right. And I think that there had to be a lot of support too. We did make efforts to be sure that people were taught about putting on and taking off PPE, that people, as best we could, were observing colleagues, making sure people, wore PPE when they went into rooms. I mean, that we were very, we tried to be very strict about,
All right, and now getting to the recent letter that you authored in JAMA Cardiology, can you take me through a bit of what your experience with COVID-19 was like, sort of the timeline, the symptoms, the severity, and then what it was like returning for work with you?
Sure. Why I felt like I wanted to write something about it was that I feel that for us as clinicians, feeling that other point of view, it was very important for me, in how I thought about what I do here, and what it was like for patients to express that. So what my story was that I, worked in the intensive care unit, and I developed COVID and recognized that on one day when I lost my sense of taste while I was working. I didn't taste my lunch, and I thought that was very curious. And actually, it was the following day that there was an article about that. So I thought it was strange, but then, put it together, and then had some cough and low-grade temperature. And so I had to go home. I had a COVID test, which was positive, but had to be at home, until I was cleared. The feeling of having respiratory symptoms from COVID, that I feel was, a frightening feeling, just because, we would see what happened to patients who developed initially mild respiratory symptoms, and then perhaps, within the 2-week period, even if he felt better, within 2 weeks, we were seeing people coming back with severe respiratory failure. So I, was conscious of that. I, luckily as a physician, I knew I could, before everyone now is being told to do this, I could get a pulse oximeter and watch my saturation. And I thought to, try to sleep prone and, the things that we would do in the hospital, and just treat symptomatically. And I felt better. So I did return to work as soon as I could, because this was a very stressful time, in terms of the numbers of patients and how hard the staff, everybody was working so hard. All of my colleagues were working so hard. And so I was definitely very eager to get back. And, I was also trying to work from home in terms of helping with the scheduling and making sure everything was running smoothly for critical care, and really didn't want to miss this. This was so important for everybody, and everybody really banded together. And, for the time that I was out, there were other physicians who, rose up into the leadership positions. So everybody worked very, very hard. So I was able to come back and then worked for a few days, but then realized that I really wasn't, I was feeling worse, and felt short of breath, some chest heaviness, and just tachycardic, like my heart was always racing, even when I woke up in the morning. So after seeing that my chest x-ray was negative, I talked to my colleague, and I think that this is it's, we're sort of blessed when we work by having colleagues in a hospital, so that I was able to talk to, a colleague, go into the echo lab and ask my colleague there, a cardiologist, to evaluate me with an echo. And, I realize part of, in telling my story is like the access to care that we have as physicians, that at that time, if you were sick out in the community, I think it was very hard to get. You couldn't go into a doctor's office. You didn't want to come to an emergency department, because all the emergency departments were really so busy. And I think that patients, it would be very hard to come in and then, feel like you had a lot of exposure to COVID. So I was very lucky. I, had a colleague who's a cardiologist who ran the echo lab, and saw that my echo was not normal, that my ejection fraction was decreased. And, I knew that was the problem. At that point, my physicians suggested considering being admitted to a telemetry floor, because with some cardiac dysfunction, we don't know, was it going to get better, or was it going to get worse, or would there be some arrhythmias involved? And I really felt that I would be more comfortable monitoring myself at home. I think, part of what I was writing about was my impression of how difficult it would be to be in a hospital. At that point, there were no visitors allowed, period, in the hospital. So once you were admitted to the hospital, you could talk on the phone, or, we had, iPads with Zoom meetings for families and patients. But I thought that would be very hard to be in a hospital, and I felt like I could watch myself at home. So that's what I did for the next week, and just monitored my vital signs, had follow-up echocardiogram, talked to my physicians, until I was really feeling well enough that I could come back to work. So I'd say that that whole period was about a couple of week period.
All right, thank you for that. And now let me ask you, I know it almost seems like it's a requirement to work in ICUs, but most clinicians in ICUs are incredibly resilient. Have you found that having COVID-19 and sort of experiencing some of the symptoms has helped you in any way as a clinician?
Yeah, I do. I feel like I have experienced, with life experience, your family is ill, friends are ill, people have illnesses. But to really feel that as as a patient, what that, fear is, and, fearing that you could die from this, and, that you could, have more symptoms. Um, I realized how vague the symptoms were. So I kind of got it when patients, so I mean, that's like, I mean, sort of, help me understand more when it's really hard to pin down when you feel unwell. Like, is it chest pain or is it pressure or is it, a strange feeling, like it's very hard. And I think that maybe that's why it's very hard sometimes to even diagnose a patient, because the symptoms can be very vague. And I experienced that, and I have a better understanding of how a person describes their feelings, of feeling unwell or feeling like there really is something wrong, but it's really hard to put your finger on it. So I felt like I kind of had a better understanding of that. I also really felt that, having other people was so important. And I have always felt that having visitors in the intensive care unit 24 hours was always very important. I was always an advocate for just open visiting, because I really felt like families are what are the North Star for the patients. And I think that that's why at this time I felt that although we had to restrict visitors, obviously this was, a state mandate. We had to restrict visitors for their safety, and, just for, containing the pandemic here, that was very difficult for any patient and for the visitors, their own, physical and mental health. And so when I felt like I did not want to be in a hospital, um, uh, you know, um, I felt like, that was a lot of it. It was just, the experience of, loved ones, community. I think that was one of the things that was so difficult for people during this pandemic, was just the isolation. So I feel like I always felt that before, but, I definitely have another respect. And I think it was very hard for the nurses, for the physicians to see patients alone. That's something we weren't used to seeing. And that, I think that was very hard, one of the things, just as an aside, one of the things that we worked on within our fellowship and the fellowship director, before this, was an initiative to try for clinicians in the ICU to know their patients a little bit better by getting some biographical information from their families and reading it aloud on rounds, so that we would know something about our patients more than what their disease was. And so then during the pandemic, when there was nobody in the ICU, we kind of pushed this out again so that we would get some information, so that we would know something, just to feel that like connection, like a human connection. So I feel like that was something to learn about this. So I think it was the being sick, the fear of illness and death, the fear of isolation, that I think that people experience when they have an illness, and especially this illness. And so as far as the resilience goes, I think that I feel like, you know, a lot of clinicians have this resilience, like we just have to keep going. Um, and, you know, like when I would see the nurses just going, you know, every day, like all the time, like fearless, you know, I think we have that. But of course, you know, not everybody feels that. And I think that people can have some times when they really feel exhausted and sad and depressed. And I mean, I feel like that's why we as physicians really, I feel like we need to talk about this, you know, more, because, you know, something like, I mean, COVID, that's a real existential threat. I mean, it's not, I mean, it's, you know, it's really in the big leagues. So, but I think it's the group, and I feel like I felt like I needed to come back, and, you know, I'm very happy to work because everybody was working. And if I'd say one thing about the whole experience, it was the teamwork. And I think that if we have a good supportive team, then I think that really helps with resilience here.